So I put together a few cases regarding dementia and hospice criteria, and this is something that in hospice we actually struggle with quite a bit. And please chime in with questions. I have 5 cases. We don't necessarily need to get through all of them depending on the time and the discussion. So first of all, let's just start off with a case. Mrs. S. is a 90-year-old female residing in a nursing facility with a history of Alzheimer's, dysphagia, controlled CHF, and arthritis. She's pleasantly confused at baseline. She is now more confused with decreased PO intake for the last 36 hours. And the ARNP that is assigned to the facility suggests to the family that hospice should be considered at this time, and the family says that sounds good to us, and they put in a hospice consultation. So not an uncommon kind of scenario. I'd like people to think about this, and what other questions would you have right off the bat regarding this patient? Anybody? It's like everybody's muted.
Oh, Carrie has a question. I think you're still muted.
Yeah.
Oh,
There you go.
Any other symptoms or signs that the reason for her decreased PO intake is because of an
Right.
infection, or she's feeling poorly, anything easily reversible?
Right. So you're thinking like a geriatrician. What else could be going on to make this decline? So for the sake of discussions, let's say she doesn't have a fever, there hasn't been any med changes, there's not the flu going around the facility. There's no other big clues as to why she's declining.
And I'd want to know how advanced her dementia is.
Right. So let's say that at baseline she is able to carry on discussions but can't track. She'll forget. She doesn't have orientation to her place. Can still talk with staff and family members, and she's losing ability to remember her family members, but for the most part can have a good conversation with them.
And was the ARNP suggesting hospice based just on the decreased oral intake for the last 36 hours, or is there something else to the story? Because it sounds like her dementia to me is actually not severe. She's really quite functional.
Right, so she's had an acute change, more confusion. Let's say now she is just saying a few words in response and just kind of sleeping a lot more, slumped over in her chair, and really drastic decline in eating. Yep, Amy?
So I was thinking, you say that, she may not show that she's having an infection or she may not have a fever, but she could be having an infection. And also if she's not having any PO intake, perhaps she's also not taking any medications that are normally were used to
Right.
control her
Right.
CH.
Right, all good thoughts. Let's say for the sake of argument, they're still able to have her take her medicines. So there hasn't been any change there, but yeah, an infection etiology, of course. So this is not an unusual scenario that we get from hospice, and the hospice criteria is that a physician, it actually can't be an ARNP, refers to hospice, and then the hospice medical directors have to second that referral and say, yes, we agree that this patient qualifies for hospice. And unfortunately, we get little information at times, or perhaps somebody hasn't seen this patient. This could have come from the family member, and the patient hadn't been seen, maybe living at home and hasn't seen a doctor for 3 months. So, oh, she's not doing well, we want hospice. And so it's really on the hospice ends to say, okay, what else is going on? But it's easy to say, oh, here's a person with dementia, they have a significant decline, they're not taking food or water, their DNR, the family doesn't want anything else hospice. But it doesn't mean that they necessarily qualify. So, oops, is that going to the next? So here's some of the hospice criteria, and I want to stress that this is not anything that's set in stone, but this is what we look at, and this is from Medicare. So there's the FAST score, and the FAST score isn't really used that much within geriatrics, but it's used all the time within hospice. It's a scoring that was developed for Alzheimer's specifically, but we do use other types of dementia with the score kind of to help us track how people are moving through the disease process. So the hospice criteria are really, you have to have a FAST score of at least 7A. We're just speaking a few words in a day, and a secondary symptom. So if somebody is significantly demented, not speaking, not able to sit up, that is not enough in itself. There has to be another factor in the picture. Otherwise, we're really looking at a custodial picture, and we all know that people can have very advanced dementia and not change for a long, long time, for years. So Mrs. S in our case would probably be a little above 7A at baseline. Of course, she's had an acute change. So she might not meet that first criteria, and we don't have any other clues for secondary criteria. We don't really know about weight loss. We don't know about pyelonephritis. Certainly a UTI is probably the first thing to look at in her case, something that could be addressed and treated relatively easily. I think having a case like this going for hospice, there's a lot of question marks that have to go, but a lot of times the family and physicians or staff at a facility, we don't want to check urine, we don't want to do anything, and that's a little bit tricky. I don't have a slide for this, but I did want to point out that there's really four buckets people can go into for meeting hospice criteria. One is that they completely meet the hospice criteria without any doubt, that Mrs. S would be, her FAST score and secondary symptoms would completely fit. The second criteria would be, or the second bucket would be, if she's close to these criteria, she doesn't quite fit, but her clinical decline is such that it fits a prognosis of 6 months or less. And then you would tell a narrative of why you think this is going to be 6 months or less, even though she doesn't quite fit the criteria. And that should be good for documentation. A third bucket would be that she doesn't quite fit these criteria, but there's CHF, there is COPD, there's cancer questions or issues. So there's a bunch of other comorbid factors that really add up to a very poor prognosis and a decline that would be 6 months or less and very defendable in documentation. And then the final bucket is just your clinical opinion, and you can do that, say, in my clinical expertise, this patient has 6 months or less based on X, Y, and Z. But you have to be very, very careful and very clear to state why that is, because if Medicare auditors come in, they want to have something to hang their hat on, and if it's not objective data, that puts you at a little bit of risk for the hospice at risk for not getting paid for that. Any questions about that? This is something within hospice that we've had people on for 6 months or so, and we look back at these criteria, and if they're really not changing, even if they're advanced, they really are a custodial patient, and then we have to figure out, do we have enough with hospice to document that they're still meeting criteria for hospice services. Okay, let's go on to, this is just a slide I threw in there. I think everybody really knows the aging of the U.S. population, and that the greater than 85 is the biggest group that's advancing in age. that change in demographics really does have an impact on hospice enrollees. In this slide, this is from NHPCO, the National Hospice and Palliative Care Organization. In the middle kind of slice there shows that really the point I wanted to make with this is that the proportion of patients that we're getting with dementia for hospice is increasing. Alzheimer's is now 11% of all hospice admissions, so it's the most common primary diagnosis for hospice. Cancers make up 30-some%, but it's all different types of cancers. So the percentage of people that are entering hospice with a primary dementia diagnosis, Alzheimer's and other dementias, is increasing and is going to continue to increase. And Medicare is paying very close attention to that because dementia is really, really difficult to prognosticate. There's a lot of dementia folks in facilities, and we have about 70% of our hospice organizations are for-profit. So Medicare is very, very interested in how this shift is going and how we're going to manage this. The other point I would make is I really do think that hospices are still very much under a cancer paradigm. You know, we give out our comfort kits, which is like morphine and lorazepam. It's not under a dementia paradigm, and I think we really need to be aware of that and be smart enough to say this is a different class of patients that we have under hospice. Any questions about that?
Can I actually ask a question about the case?
Yeah.
I feel like I have definitely seen at least a couple of people with dementia who are fast, probably 6 or better, not quite 7A. But they've had in the last 12 months something like aspiration pneumonia. Mm-hmm. But overall, my clinical sense is not that they have 6 months or less. So in that case, if family, for whatever reason, or patient did want hospice, but I don't think that it would be 6 months or less, would they still be candidates?
Well, there's a lot of gray area in there, but if they don't meet the criteria, they don't meet the criteria. And again, if there's other factors that you can put in there to say 6 months.
I think I was unclear. I guess I'm trying to ask if they do meet the criteria for whatever reason, but they actually are doing better than you would expect.
Right. Sure. Oh, sure. I think there's a lot of people here that you would say, oh, they meet the criteria, but you think their prognosis is greater than 6 months. Absolutely. Yeah. I mean, if you think about an average nursing home population, the FAST scores, and how often do we get UTIs? And the other thing that's not on the list and really doesn't count, but falls, increased sleeping, those aren't criterias, but those are common things that we see. Like, oh, they're sleeping more. Hospice. A 90-year-old sleeping 18 hours a day, I'm not sure what to make of that. That happens.
So then in that case, it'd kind of be a case-by-case basis if they did want to try enrolling in hospice?
Right. Well, they have these criteria and you think that their prognosis is 6 months or less.
Okay, thanks.
Right. If you think their prognosis is 6 months or less and they don't meet this, then you have to defend that in a narrative. Okay, let's do number 2. Is Mr. P has mixed Alzheimer's, vascular dementia. He's non-ambulatory, losing weight, and becoming more aggressive with staff. He's in an adult family home. A hospice RN calls asking for medication to improve his behavior.
What are some of the examples of his aggressive behavior?
So let's say he's striking out at staff. He's, you feed him and he throws his food or his fork. Much more difficult with daily care needs. Bathing is difficult. He's getting more, I don't have this on a slide, but let's say he's getting a little bit more confused as well. So he's on hospice. So this is, I mean, you see this in nursing facilities too, that, oh, you know, there's behavior, you know, they call you up, you're on call, you know, what can we do? With basically, what medicine can we give them, right? So this case, I'm just kind of remembering the cases because I've forgotten what I put together, but this case really, I think, points to, you know, hospice isn't geriatrics, and I think we miss a bit with our geriatric syndrome patients in hospice. And if you look at this case from a geriatric perspective, it's different than a hospice perspective. So a hospice would be, well, they are dying, and so let's do whatever we need to do to keep them comfortable. From a geriatric perspective, you don't want to just look at medications for behavioral issues in somebody with dementia. You need to look at the environment, what's happening with the adult family home, the caregivers. Is there a new caregiver? Other environmental factors that might be in the home. And so when I get calls like this from our hospice staff, those are the questions that I ask to really, again, try to minimize medications like we would in any geriatric patient. Just because they're on hospice doesn't mean to medicate and sedate. Go on to the next one. And we have two cases we'll get to that were sent in. So Mr. H is 85 on hospice for 7 months. So he's been a month later than initially thought. He was initially admitted for a CHF exacerbation, but this has been pretty stable, and he's not short of breath at this time, has some edema. So as we're going along, the hospice team said, oh, you know, maybe we should really change this to dementia. That really fits better. Weight has been stable, and his FAST score has changed from a 7A to a 7B, so he's only saying a word or two a day in that time frame from being admitted 7 months ago. So the question here is, he's stabled out from his CHF, and that was the initial admission. Does he qualify for hospice at this time? Anybody?
I want to say yes.
Okay. Grace votes for yes. Oh,
How about a thumbs up for yes and thumbs down for no?
no. Okay, we got one thumbs
Not
down,
everybody.
2 thumbs
We can see all
down,
your
1
thumbs,
thumb up,
so, all right, we have
3
some
thumbs down,
Gotcha.
thumb
Thumbs
up. Okay, thumbs up. So it's pretty, almost 50-50. What else would you want to know?
Has he had any of the secondary symptoms that we talked about?
Let's say no, he's been stable. So I don't think there's a set yes or no answer, but I would probably say that this would be a little tough to defend to Medicare, because he's really more custodial. There's not much that hospice is doing. His weight is stable. That's a big thing. We could check. We could do albumin, pre-albumin, and see if that's really crappy. But if his weight is stable, let's say his body habitus is what you would expect for 85, so he's not wasted. You know, maybe he had his CHF exacerbation at that time. You know, he got through that, and that hasn't been an ongoing issue. So that's a common thing too, where there's one diagnosis somebody gets admitted for. CHF is a common one, or COPD. They get good help with hospice. Their medications are managed. They get a nurse check every week, and so the primary diagnosis becomes a secondary diagnosis, or something else that comes up. So it's fine to change the diagnoses. It's actually, you need to change the diagnoses, particularly if the CHF is no longer a terminal diagnosis. But then you have to go back and defend what diagnosis you're going to. Does that make sense? Okay, next one. Mrs. A is 80 years old. She has Alzheimer's and is frail, cared for by her husband. She has been losing weight, had difficulty with pressure sores despite a hospital bed turning. Her husband is her primary caregiver. He has mild dementias, but is looked on by their daughter, who stops in regularly. He is very adamant that he doesn't want any further help at home. But the hospice RN is seeing that he is very fatigued and is not looking so hot. Again, this is not an uncommon situation in our hospice or dementia patients. There can also be situations like this that have cultural aspects where, for whatever reason, they don't want more help, they don't want other people in the home, or they have a set way that they want to do caregiving, and the hospice staff is a little concerned that way might not be the best for the patient. So any thoughts about this one? Karen, you might have thoughts.
Thoughts on how to have them get more help?
Yeah. So.
How to kind of talk with them about being open to more help.
Mm-hmm.
Mm-hmm.
So Karen did hospice social work for a long time.
A long time. Yeah, I mean, I think that, I think that kind of checking to see things that might be motivating. So like, are there
Mhm.
barriers such as, is it a concern about finances? If so, do they have like a program that's straightforward, like the COPES program, where they could easily qualify for something like that?
Mm-hmm.
Also exploring about, options about adult day health, if it's something like, perhaps it would engage with him if he thought she could benefit from more socialization, and kind of
Mhm.
normalizing that is something that can sometimes be helpful. A side benefit would be, it would be allowing him to have some respite himself, although depending on what's motivating him.
Right.
You'd want to kind of see what it is that's kind of the sticking point, explore that a little bit more, and then try to kind of like match options for that.
Right. We really need to know what's going on in his head about his resistance to more help, and obviously get the daughter involved. So this is a caregiving issue with someone with dementia, and hospice has the responsibility of making sure that patient is well cared for and safe, to the point where this could be an APS issue if we can't help the family in other ways to get more care for her. We don't know if her weight loss is related to difficulty of him feeding her, or if it's part of the dementia, maybe both. But this goes into both, family support, caring for somebody with dementia, but also making sure that, as mandatory reporters, the hospice is doing the right thing in caring for the patient. And sometimes this can get actually pretty unfortunate, where APS is called, and they have to take, either the patient into a facility or some other measure, and that's, it's very sad. We never want to do that, but it happens.
Maybe we can shift to our
Mhm.
other cases, if that's right, Dr. Burnside.
I
Are
think-
there,
I'll do one more.
okay, sure.
Yeah, so you probably know this, what's covered in hospice, the inpatient care, continuous care, respite care. So hospice patients can get 5 to 7 days or so, it's not set in stone, of where, and this could have been our last case, where the patient comes into a nursing facility to give the caregiver a break. That's part of a hospice benefit. Caregiving is not covered in hospice. And I just wanted to point out, this is Joan Tino, who's here at the university, did this wonderful paper looking at the cost of hospice, comparing 2004, 2009. So there's been a huge increase in the number of patients enrolling in hospice. And everybody, and one of the edicts in 1982 of hospice was to save money. Hospice doesn't always save money or cost less, and her paper is a very good example, actually cost more in the nursing home setting. So I just wanted to mention that, and again, that's something that Medicare is looking at very closely, and some useful sites there